I can't stop having diarrhea. I've had kidney stones again.
I started a new medicine.
They all have metabolic acidosis, but their anion gap is normal. No excess unmeasured anions? Then, where did the bicarbonate go? Only 2 places?
Bicarbonate is lost through the gut or through the kidneys.
The bicarbonate is leaving through the intestine.
This is gastrointestinal bicarbonate loss.
Chloride replaced the lost bicarbonate.
That's why the anion gap stays normal.
The kidneys can lose bicarbonate too?
Not every normal anion gap acidosis comes from the gut. I've had kidney stones again.
My doctor started me on acetazolamide.
Both of them went through the kidney door.
Now let's find out why. The kidneys can lose bicarbonate. What else causes metabolic acidosis?
They fail to excrete acid?
Type 2 RTA and acetazolamide impair bicarbonate reabsorption. Type 1 and Type 4 impair hydrogen ion excretion. Let's start with the first group.
The kidneys are wasting bicarbonate.
Exactly. Bicarbonate is lost in the urine. Which part of the nephron wastes bicarbonate in Type 2 RTA?
The proximal tubule.
Exactly. It fails to reabsorb filtered bicarbonate.
My doctor started me on acetazolamide.
Why does acetazolamide cause a normal anion gap metabolic acidosis?
Let's investigate.
Carbonic anhydrase is blocked.
Without carbonic anhydrase, the proximal tubule can't reabsorb bicarbonate.
Type remove the acid.
Type 1 fail to excrete acid. Both fail to excrete acid, but which one causes kidney stones?
Type 1 RTA.
Exactly. I have another kidney stone. Luna, why does Type 1 RTA cause kidney stones?
During metabolic acidosis, the kidneys reabsorb more citrate to make bicarbonate. Less citrate reaches the urine, so calcium combines with phosphate. Alkaline urine helps calcium's calcium phosphate stones form.
Exactly.
Why does Type 4 RTA cause hyperkalemia?
Let's look at aldosterone.
Reduced aldosterone activity decreases sodium reabsorption. Less positive charge leaves, so the lumen becomes less negative. A less negative tubular lumen decreases potassium and hydrogen secretion. Potassium and acid build up in the blood. Why is aldosterone activity reduced in Type 4 RTA?
Diabetes is the most common cause. Some medications and adrenal disease can also reduce aldosterone activity.
How do we know which door our patient went through?
We look for the kidney's clue.
That's all we measure?
Exactly. This simple calculation tells us whether the kidneys are excreting acid.
If ammonium removes acid, why don't we measure it?
Most laboratories don't measure urinary ammonium directly, so we look for another clue.
Ammonium leaves with chloride.
More NH4+ means more chloride.
So chloride tells us how much ammonium is leaving.
She's losing bicarbonate from diarrhea.
Wow, so her kidneys are removing more acid.
Now let's calculate her urine anion gap.
More chloride makes the urine anion gap negative.
A negative urine anion gap means the kidneys are excreting acid appropriately. Luna, do you remember this patient?
Yes, she has Type 1 RTA and calcium phosphate kidney stones.
Now let's see what her urine anion gap tells us.
The kidneys aren't removing much ammonium.
The kidneys are not responding appropriately to the metabolic acidosis.
Less ammonium means less chloride, so the urine anion gap becomes positive.
A positive urine anion gap tells us the kidneys are failing to excrete acid.
Negative urine anion gap means the kidneys are responding appropriately. Positive urine anion gap means the kidneys are failing to excrete acid.
Excellent.
Now I know how to diagnose normal anion gap metabolic acidosis. Another mystery?